Okay, we'll do the introductions as it were. So if you look at the PowerPoint, I'm at the Blackboard rather, and on three is where I'm stashing all this, the lectures and things like that. Uh, the PowerPoint from the Cowan textbook is antimicrobials, that you can see here. I'll open with this, the Nestor antimicrobial PowerPoint, just for some historical, because they do those, and I like that. And then I have an outline, which I thought perhaps I had sent to you earlier, but it appears I did not. And here that is. So it kind of, and what it basically is a summary of the Nestor chapter more than anything else. Some of it's changed over time. When I first did this, probably 15 or more years ago, again, we have antibiotics with different names and different concerns, more than you'll see, but it's not necessarily a bad quick overview. And what is it, 3 or 4 pages long, nothing really major there. That's part of it. So, without further ado, we will do this. So, I'll start with that. Oh, let me make sure. It's my furious need. I get this from my dad. Okay, it's this uncontrollable need to double check things. My dad was an awful double checker. I mean, we'd get in the car, drive a block, and gotta go back and make sure the doors were locked. I'm like that. Thank you, Sid. What are you doing? Okay, and moving on. So let me get back to where this was, this part. So this starts here. And again, I like the little historical stuff because it's fun. There was a movie with Edward G. Robinson in 1940 called Ehrlich's Magic Bullet. Uh, and, a long time ago, but they'd love to do those biographical type movies and things like that. So here's this guy, Ehrlich, and the disease that was affecting him because it was sexually transmitted, and the notion that having sexual intercourse could be something harmful to people it was just not something that was understood. That a natural activity would be create all these, not really understanding how diseases spread, and that being certainly a very problematic way that's there. And so what he here it was Ehrlich. So some dyes stain bacterial, but not animal cells. He knew there was a fundamental difference. So he's searching for, and the idea of a magic bullet, and this is the whole idea of antimicrobials, is a concept called selective toxicity. More harmful to the invader than the host. Something that kills them and doesn't hurt you would be the optimal, the best thing going. And so that was a so-called magic bullet, kill the microbial pathogen without harming the host. And so he started playing around with arsenical compounds. Now, arsenic is a toxin, rat poison, what it was used for. But historically, they had used arsenic or arsenical compounds to treat quote unquote nervous disorders. People had disorders of the nervous system and tics and things like that. And even it was probably working on it more as a toxin than anything else, but he played around with it, and he was looking to address the organism that was caused syphilis. Syphilis has been around forever. I mean, syphilis is one of those diseases back in historical times that were there. And the 606 tested compound was effective. He named it arsphenamine, and the name that they gave it colloquially was called salvarsan, or salvation from arsenic. Lethal for patients, did cure infections that were considered hopeless. Some chemicals could selectively kill microbes. The cure was worse than the disease. In many instances, what they used to do was mercury vapors. Mercury is a horrible neurotoxin. And they used to get mercury in a closed room, and you would inhale them, and the lesions, the sores from syphilis would disappear for a period of time. People always thought they were better, then they come back. So I mean, it was really something that was very, very difficult to treat. That was the start. So that, technically speaking, was what would be considered an antimicrobial, not an antibiotic, because it was not something that came from other microorganisms. We'll get to that from a definitional standpoint shortly. So, and then, imagine, all this type. You can look at that. So Ehrlich, Prontosil. This is in 1930. Now we're up to 1932. Then he took a dye. Why is that not antibiotic? Because most of the time dyes came from plants, and plants were not other microbes. berries and roots and leaves, that kind of thing, where you would typically find that. And it was being used to treat streptococcus, which they were aware of, infections in animals. But it was, and this is a perfect example of what's, and you'll see this again and again, the distinction between in vivo, in life, and living things on us. Why is it when we take a pill, it works, or why doesn't it work? What's going on? Why? Oh, it didn't, that antibiotic didn't help me at all. And you said it would work. That's what doctors get all the time. The reality is, when you put something in your body, there are other mechanisms that can cause it not to be as effective. Some things work great, and we're going to talk about an antibiotic that all of you will have been acquainted with at some time during your lifetime, called ciprofloxacin, known as Cipro. It is the go-to drug for gram-negative infections. It's the go-to drug for bacterial infections in E. coli and things like that, particularly in the urinary tract of significance of significant severity that are there. Cipro is a wonderful agent. It doesn't, in the laboratory, it clearly, consistently destroys staphylococcus and streptococcus. In your body, it does not work on them at all. Why's that? That whole Curry Bauer test, what's that all about? Well, the reality is that it's a test, it's a lab test. And you can't do medicine by a lab test. You can't make people better by a lab test. All it is information. So the distinction is between in vivo and in vitro. This was a perfect example. Not effective in a test tube, but there were enzymes that broke down this red dye into really the first of the sulfa drugs, called sulfanilamide. And we still use sulfa drugs today. As a matter of fact, they've moreover become the go-to agent as a first choice agent to start to treat MRSA before you get to the big boys. How's that? Why? Because we didn't use them for a while, and it was sort of like out of sight, out of mind. The staff hadn't become acquainted with it. And now it's used commonly. It's a very interesting story that we'll get to. So those are also antimicrobials. What's interesting historically, if you like, and I love this stuff, sulfanilamide, it was originally formed as a greenish looking powder that the soldiers, the Allied soldiers in World War II, carried in their packs. Remember, they didn't have chopper evac, there wasn't MASH or anything like that. They had field packs. And so what happens if somebody was injured, a squad went with a medic, and the medic would sprinkle this stuff on the wound, like it was an open wound, bone exposed, that type of stuff. And it was extraordinarily effective at stopping gangrene. It was something we had, and the Axis forces, the Nazis and the Japanese, did not have. It was a major reason why the war, World War II, was won, because it was a war, like most wars are, of attrition. Their soldiers got gangrene, they had to amputate. Our soldiers got less, we had more soldiers. It's very, very interesting. There's so much to it historically about these things, and I'm always fascinated by it. But I threw that in there for the sake of completeness, which brings us to really what optimally, if it had been used properly, would have been the best antibiotic. Okay, it's the ultimate in selective toxicity. It targets something that only bacteria have. What do bacteria have that's unique to them that nothing else has? Peptidoglycan. Remember that first week? Peptidoglycan. Okay? With the peptidoglycan, that's what bacteria have. This targets peptidoglycan specifically. It's called a cell wall antibiotic. So why don't we use it, and why can't we tolerate it? Okay, it comes from a fungus, there are allergies. I'll buy that. Okay. So allergies are the big problem with that because of its origin being fungal. It is an antibiotic because, being from mold and fungi, it comes from one kind of living microorganism that targets another living microorganism. And we tinker with it in the lab, and then you're going to see that's the definition of what are called semi-synthetic. Semi meaning partially synthesized or partially made in the lab. And so all the other penicillin lookalikes, amoxicillin and methicillin and nafcillin and ticaricillin and piperacillin, and need I go on, okay, are all considered semi-synthetic penicillins. And this was an accidental discovery. I alluded to that at the very end of the last time we met. So Fleming, hack, okay, 1928, You would have failed. He would have failed lab if he was in your lab. He contaminated his culture plate. Teacher would have gone in and go, "You Fleming, you blew it. There's mold growing on your plate. You don't know what you're doing." Except he was smart enough to realize when he looked at the plate that was probably had a tuna sandwich on white in the lab. You know, you don't eat in the lab, and some of that from penicillin mold, white bread mold, got in on top of his staphylococcal cultures, and all of a sudden he's a mound of fungal mold growing on his plate, and surrounding it, you guessed it, a zone of inhibition, just like you look for in the Kirby-Bauer test. And so he all said, "Hey, I got something here." Okay, he couldn't purify it. So 10 years later, his original paper was in 1931, they gave it to these two doctors who in 41 had made enough to treat a police officer, dramatic improvement, but ran out, and unfortunately the officer died. And at that point, what happened was, in World War II, with all those war wounds, here's another thing on top of sulfanilamide that the Allies had, penicillin. Pfizer Labs, the biggest laboratory. Many of you had the immunization from Pfizer Lab. Okay. The biggest pharmaceutical maker in the world now dedicated its operations in Brooklyn, New York to making one drug in 1941, penicillin. How's that? So it's a fascinating history about antibiotics. You should read it, and I think you're interested. And this is sort of like penicillin genealogy, the family tree of penicillin. I usually do a whole spiel on that, but I'll save you from being bored to death by that right now. So let us move on. And it's interesting, just for the clarification, what they found out about penicillin, and they used it on everything, it worked wonderfully on gram positives because it targeted peptidoglycan. Oh, those 30 to 40 layers, gram positives. Remember that from early in the class? Come on, you knew. Okay. Didn't do much for gram negatives. It only took care of gram negatives that were relatively fastidious. Read that as easy to kill. So, what did we do? We started looking for more. And they found a bacteria about in the early 50s from a researcher named Selman Waxman from this called Streptomyces griseus. It's a spore-forming soil bacterium. Not quite endospores. It sort of grows differently. And what happens, they were constantly looking at soil samples, and that turned out to be the parent of another group of antibiotics that we look at called aminoglycosides. And he named it for the genus that it came from, streptomycin. So a lot of times you'll see antibiotics have the N name mycin. Tetracycline was terramycin. Tetracycline that's used more commonly today, and it's a very good agent called vibromycin that you hear about a lot, and you undoubtedly will. Many of you going into medical-based fields will learn a lot about vibro. So they say mycin. I used to have patients go to me, "Oh, I'm allergic to all the mycins." Well, they're not all from the same group. And so back to that when you're doing histories about people, and I'm allergic to all those mycins because they probably got an upset stomach. That's a side effect. That's not an allergy, but we'll get into that as well. So to me, it's just a fascinating area because really the rest of this class, I hope to make it mostly about therapeutics, what makes diseases, how we treat diseases, what to watch for in diseases, what the risks are, et cetera, et cetera. So the first drug, penicillin, gram positives. The second one, negatives. The third one, probably tetracycline from a similar soil bacteria, kind of hit both. So it's interesting just sort of from that historical perspective that we see that. So let me go back to the PowerPoint from the text, which I feel obligated to use since some of you paid for that. The main goal of antimicrobial treatment, get better. Source of most commonly used antimicrobials, other microbes, bacteria, fungi, and molds. Testing is lab, Kirby-Bauer is one of them. There's a couple of others. Therapeutic index, really important term. I told you the goal of the exercise is selective toxicity. How do we measure it? Selective toxicity, it's got to be selectively toxic and be successful. It has to be something like this. So you have an agent where the lethal dose has always got to be substantially higher than the effective dose. So what they call the LD50, or lethal dose for the 50th percentile, let's say arbitrarily for a drug it's 90 milligrams. And the effective dose, the dose that they might prescribe to you, and this is by no means great, at 50% of the population, ED50 would be 10 milligrams. Okay, what the therapeutic index referred to forever as the TI, or therapeutic index, as you can see over there, equals, we just make a ratio, 90 to 10, 9 to 1. It's therapeutic index, so it's 9 times more likely to help you than to hurt you. That's good. Higher the better. 100 would be great. Some have, penicillin has an extraordinarily high therapeutic index. You can express it in that ratio, or you can use this. It's called a safety margin. Safety margin, we don't make it a ratio, we make it to an absolute value. 90 minus 10 equals 80 milligrams. So the margin of safety is just that. How wide the gap is between the lethal dose and the effective dose. For antibiotics, that's somewhat, you have to think of it this way. A lot of people think, well, if I get one pill, 5 will be better. That's part of the education you have to do if you're in the healthcare tree, is to tell them it doesn't work that way. There's a reason we prescribe something 1-3 times a day. It has a lot to do with the half-life. That's the amount of time that's effective in doing what it's supposed to do. Half-life is another interesting thing. There's a lot of definitions. The typical definition in medical-based and biological science is the time it takes for half of the dosage to be metabolized. What that means, the time it takes for half of it to no longer be the same drug that was administered. It doesn't necessarily mean not effective. It means it's changed. In general, it means it's lost its potency or its effectivity. Potency is the wrong term. Efficaciousness, as it were. Okay, so that plays a role in it as well, and I'll talk a bit more about that as time goes on. So we'll probably see the definition. I'm sure I have it in that handout for half-life. Half-life is important with regard to the dosing. And a lot of this, and they allude to this in this chapter, is the psychology of patients. In the old days, most of the agents we took were X number of pills 4 times a day. I don't know about you. Maybe, do you remember to take it 4 times a day? Do you set it out? I will tell you, for an older person, it's pain. They don't remember. You put in those little plastic containers that you've all seen for grandmas and great-grandmas, or people like me. Okay? Don't start. That it's hard to, you're saying, oh, God, I took that this morning. I don't feel like taking it. F it. Did I say that? I meant to say with some effort to take that. I just misspoke. Still asleep. You can tell Sadie's just not awake yet. Gotta stop going out late at night to those clubs. I'm telling you. She is. So the whole idea is, you're going to see today that a lot of medications are designed for once daily dosages or twice daily dosages. You get better. The watchword is compliance. You're all familiar with one. Everybody thinks it's stronger. No, it's about the half-life. It's called the Z-Pack. It's formulated for a delayed release, so that in a matter of taking one dosage for 5 days, effectively you get dosage levels that are sufficiently effective over a 10-day span, the usual span that's necessary until your immune system's ability to produce its own antibodies. You already had that immune system stuff in AP2, didn't you? You know, the first one, you know, how it makes the first level, and about somewhere between day 10 and 14, it ramps up. Remember that chart? It's in the book. See? All comes together. So, therapeutic index. High is better than low. About 1940s. Yes, they have helped a lot. It's not a panacea. The fact that it is there, it is no longer a death sentence for a lot of people. Infections were just the difficulty we are seeing now, and the underlying theme when I do this unit, and a lot about therapeutics in general, is the not just the overusage of antibiotics, but the misusage of antibiotics and the ignorance that we have had about antibiotics. Because the notion, because science was not that, we didn't understand that bacteria, even though we define them now as something living, we have to understand they undergo evolution like we do. When they first made that penicillin, it was designed really to treat, again, what still is public enemy number one, Staphylococcus aureus. 90 to 95% of all strains of Staphylococcus aureus, the most common infecting agent for wounds, by far and away, were susceptible to basic penicillin. The same stuff that Fleming guy discovered and the same stuff that was identified eventually and synthesized in that lab, okay, and generated in that lab. Today, we have not only evolved it once, we've evolved it twice in what? An 80-year span. First, we had penicillins. Most Staphylococcus were resistant to basic penicillins, and so we had something called penicillin-resistant Staphylococcus aureus. Now we have methicillin-resistant, the very famous MRSA, methicillin-resistant Staphylococcus aureus. So in a span of 80 years, we have effectively evolved this twice from not understanding the dynamics of usage. We've caused those mutations. It's a living population. It's being exposed to deadly chemicals. If you and I are exposed to deadly chemicals, we either die, or it may induce us to mutate, or the ones who survive may have certain mutations that they had and passed on to others that make them more likely to survive. Descent with modification, Darwin 101. That's exactly what's going on. So what's the goal? Administer a drug to an infected person that destroys the infective agent without harming the host. Panacea, it doesn't always happen. Easy to administer, orally, surely the easiest. Not always the way you can go. Able to reach the infectious agent anywhere, hopefully. Absolutely toxic to the agent, absolutely non-toxic to the host. Good luck with that. Remain active in the body as long as needed and be safely and easily broken down and excreted. Again, good luck with that. That's where the dosing comes in. So these are the ideal characteristics. There's so many reasons why they're not. Again, toxic, selective toxicity, microbe, but not non-toxic to the host cells. The biggest difficulty, penicillin had all that. Okay. Again, the allergy aspect of it was the problem. So what's the drug of choice? It's an important word. Drug of choice has different contexts. In addictive disease, drug of choice is the drug of choice that that person who is an addict, whether it's alcohol, whether it's heroin, whether it's cocaine, whatever it is their drug of choice to utilize for their, because they are addicted to it. Drug of choice in medicine is the drug that you ought to use. And you better have a good reason not to be using it if you choose not to use it. This is the question every doctor does not want to hear in a deposition or in an open courtroom, or any nurse wants to hear. You knew the patient, what's the drug of choice for this? Blank. You weren't using it? Why is that, doctor? Why is that? And you don't want to be in one of those, that looks bad. You lose. Drug of choice is the drug you're supposed to use. Okay? So there are significant problems with that. So the drug of choice for people who are allergic to penicillin is basically now the Z-Pak, which is the family of what are called erythromycins. Okay? The erythromycin was an agent that was discovered, let's say, from that same Streptomyces family that became something we call erythromycin. And so erythromycin, interestingly enough, has a different target. And we're going to go into all the different ones, whether it's cell wall targets or non-cell wall targets. The target, in this case, it targets the second most common area other than the cell wall, which is the bacterial ribosome. That, again, back to the first week, that 70S ribosome. Well, unfortunately, we have 70S ribosomes in our mitochondria. So the big problem with those agents is side effects. Not so much allergies, but side effects. Really, and this is as important as any. They get into a little bit in this chapter about how one decides what drug to use. It isn't just something called a culture and sensitivity, or CNS. Effectively, what you were doing in lab with the Kirby-Bauer test is doing a culture and sensitivity. The culture is used to identify the agent. The sensitivity is what antibiotics it responds to based on the Kirby-Bauer criteria, measuring those things and classifying them as I, S, or R. Okay? That's how that works. It does not explain these two things. And all of these agents we look at, we're going to classify them as either, particularly for bacteria, either bactericidal or bacteriostatic. Cidal, just like homicide, okay, kills the other bacteria. Static means it slows or inhibits its growth cycle. That permits your own immune system to do the job. Static is fine, it's not better. We always look for bactericidal, or in this case, from their definition, microbicidal versus microbistatic. That's the biggest problem. Why the three saddest words a clinician can hear when it comes to treating an infection are allergic to penicillin. Because penicillins and all of that family, potentially they're allergic to, and we'll get into this large extended family. Okay? This large extended family, at that point, you're likely to be allergic to, and that whole family is, guess what? Bactericidal. Where erythromycin, the drug of choice if you are allergic, is, bacteriostatic. So already it's a lesser degree of treatment. That's why you have to ascertain what an allergy is. Again, allergies are distinctive. Allergies are mediated by your immune system. When you're allergic to something, you look for swelling, you look for rash, you look for difficulty in breathing. Giving you a headache or a stomach ache, it is not an allergy. It's a side effect. And under certain circumstances, we can deal with the side effects. Meaning, if there's another alternative, maybe not have to. But the reality is, if this is the only thing that works and it causes a side effect, we'll deal with the side effect, as opposed to you succumbing to the infection. It's nice if things are diluted in body fluids. The potency, and this gets into the half-life and potency. Again, half-life, just to reiterate the definition, is the amount of time it takes for your body, and the term we use is metabolize or break down that agent into something else. Most of the time, it doesn't work the same. It's either less effective or ineffective. That's what makes a half-life. So when we have something that has a long half-life, we don't have to dose as frequently. Sometimes they have what are called active metabolites, which means that even the breakdown products have a certain degree of activity that may or may not be useful. Potency has nothing to do with that. So the term is misunderstood. When it says remains potent, I think it's a misnomer. I would say remains active long enough to act, and it's not broken down or excreted prematurely. That's fair. Potency is really a measure, sort of what I would call bang for your buck. I've had patients came to me and said, why did you give me such a weak drug? It's only 10 milligrams. The other thing you gave me was 500 milligrams. It has nothing to do with it. Okay? Percocet, 5 milligrams of oxycodone. It's a lot different than 1,000 milligrams of acetaminophen, Tylenol. It's all about the agent, not about the milligram strength. Potency is a measure of how powerful per unit it is. Okay. Hallucinogenics like lysergic acid diethylamide, LSD, are measured in terms of micrograms. Botox is measured in terms of micrograms, not milligrams like most of the things we get, and certainly not grams when we're talking about the typical dose of Tylenol, which is a gram 4 times a day. A gram. So potency is a misunderstood term. They all effectively lead to the development of antimicrobial resistance. Can't have that. Assist the activities of the host defenses. Most of the time they play nicely together. Remains active, again, for time limitations. Delivery. Not everything gets everywhere it's supposed to be in sufficient doses. For instance, for diseases or infections that affect the brain, we have to deal with something which you learned about in AP1, called the blood-brain barrier. Not everything gets through because of that. It has a lot to do with its solubility. It has to have a certain measure of fat solubility and molecular size to be able to get through. Doesn't have that, can't use it. Okay, so not everything reaches sufficient levels in the organ itself. Let's say in the kidney, we use different agents to treat urinary tract infections versus kidney infections. Kidney infections, you need a lot more concentration in the kidney. So you can't necessarily use the same agent, whether something just accumulates in the urine and is able to deal with the bladder, the urethra, the ureters. Okay. Allergies are predisposing to other infections. Good luck with that. So here we get with the terminology. Prophylaxis, prevention. Prophylactic antibiotics are something that we do not use routinely. You use them for people who are at risk. Okay. When I was operating on people, we had limited criteria. People with underlying infections or people with diabetes. That was a reason that you might use it. Okay. People with multiple surgical sites. More places you open somebody up, the more likely they're going to get infected. People, when you were using something that you're going to put inside, like metallic hardware, which is my level of experience, pins, screws, plates, and things like that. Okay. For that, we use prophylactic antibiotics. Certain kinds of heart valve defects might require, even for something as relatively innocuous as dental scaling and cleaning. At one time, people used to have to take antibiotics for that. Prophylactic antibiotics, they used to give them, if we're doing them orally, we used to use them, interestingly, 3 days before, day of, and 3 days after. Nowadays, if you're doing something in the hospital, you usually give a dose intravenously before the start of the surgery and another dose immediately after the surgery because people are there. It's a day procedure. And intravenous, you can get blood levels up pretty high. That's what I used to do all the time. Most of my patients were in for day surgery in the hospital. And if we were doing it in the hospital, we used like IV. I used to use IV and Keflin, which is a cephalosporin. We'll get to all of those. That was the most commonly used agent if they were non-penicillin. So there are different ways to do it. Typically, when I have to have, and I just had a urological visit, they'll give me, before they start, they'll give me a Cipro, and I'll have another one to take the next day at home. So just in case kind of thing. So it differs as to the system you're working on, things like that. So a lot of times, and I've been asked this question a lot, and you, if you're going to be in nursing, particularly be asked this question, you're discharging a patient, well, why didn't the doctor put me on antibiotics? Well, if you got a knee scoped, you don't need it. That's a clean procedure. If you had a knee scope and at the same time they decided to do an ACL, an anterior cruciate ligament repair, you're probably going to be on antibiotics. So it depends on the nature of procedure that's being done. So that's a common question. Sometimes it's not a good idea. If something's going to go wrong, let's find out about it so we can address it. So that's prophylaxis is something that's used under the appropriate conditions. Antimicrobials are anything. It doesn't matter whether they're naturally occurring or not, whether they're made in the lab or not. There's something that you're using. When we use the term chemotherapy, understand it means therapy with chemicals, addressing a problem with chemical agents. I did not have any cancer treatment today, but I had chemotherapy because I took 2 blood pressure pills. I took 3 other pills for my arthritis. It's awful. Again, try not to get old if you can help it. So the all-inclusive term, and we'll get into the specifics, antibiotics, substances produced naturally by some microorganisms that can inhibit static or destroy cidal other microorganisms. Drugs, most of the time, its reference point is bacteria because that's where we typically find them. There's not a whole lot that are in other categories. So for our purposes, antibiotics are really used to combat bacterial infections. It's interesting. We have one agent that kind of does double duty. That is an antibiotic, but it's also antiprotozoan, and you're going to see that used clinically a lot. It's very famous. It's called metronidazole, also known as Flagyl. It is the drug of choice for C. diff because it's very, very useful on anaerobic metabolism. That's what it attacks. And C. diff is in, you might remember this from chapter 4, when we talked about, not necessarily 4 in this text, but when we talked about bacterial physiology. It's called an obligate anaerobe. Here's his modifications chemically in the laboratory after being isolated from a natural source. So when we start looking at all these penicillin variants and all these cephalosporin variants, you're going to see semi-synthetic penicillins and what are called second, third, and fourth generation cephalosporins. By definition, they are semi-synthetic. Even the most common one that we use today, and if you were not allergic to penicillin and you had an ear infection, you took it, amoxicillin. Pink Chewies, the pink liquid for my kids, right? You don't talk about ear infection? Love that. I like the flavored ones. Look, I can't swallow pills. I still have to chop them, smush them, and put them in my applesauce or chocolate pudding, which I prefer. So much mousse, so little time. So moving on. So it seems like it should be natural. It's not. It's called aminopenicillin. Okay. They basically take a chemical substitution and add an amino containing group, if you remember your chemistry. We even did a little bit of that in AP1 into it. That's how you, and now versus a synthetic drug entirely made in the laboratory. Every antiviral substance, purely synthetic. There are no naturally occurring ones. Strictly laboratory origin. Spectrum of activity. For our purposes, modern definition of spectrum activity has to do with, if it's limited, it either targets effectively just gram positives or gram negatives with limited exceptions. Broad spectrum, both. It doesn't speak to how well it does it. It just speaks to the fact that it does this. A more sort of generalized definition, antimicrobials affected against a limited array. Mainly, and again, better use the term, mainly gram positives, or for that matter, mainly gram negatives, versus against both. That's really the accepted definition. So you even see penicillin effective mainly against gram positives. There are, again, some fastidious gram negatives. Interestingly, the one that causes gonorrhea, Neisseria gonorrhea, which traditionally was very, very susceptible to penicillin and was the drug that we typically used then. Changed a little bit now. It's there because we've seen some sort of upticks in resistance that are there. So there's a lot to that. The reality is people mistakenly think, oh, broad spectrums are better. Why not make sure we get it? We do not have to use a shotgun when a dissecting needle will do. And that's the mistake that was made traditionally. They put people on powerful antibiotics. What did it lead to? It destroyed normal flora, a ton of vaginal yeast infections, a ton of what are called super infections. Okay, we're by destroying normal flora, creating infections where there shouldn't be infections that were there. A ton of gastrointestinal problems, a ton of C. diff. What most of us do is we start people. This is what happened in my office. So, and I treated a ton of infections because I had diabetics. Diabetics get infections all the time. We do a gram stain. Either do it in the office or I'd have it sent up immediately to the hospital and have them do it there. And I get the report that day, within an hour. Stat means right away. And it would say multiple gram positive cocci in clusters along with white blood cells. It's a staph infection. Okay, assuming, let's say, they weren't allergic to penicillin, my go-to choice was called Keflex, something in the cephalexin. Know now that category, the cephalosporins, particularly cephalexin, Just to give you an idea of how important it is to know about this, approximately half of all antibiotic prescriptions are in that family. However, it is fairly broad spectrum. Okay. So if this, I'll tell the patient, here's what it looks like to me. I'm going to give you enough for 5 days with a refill. If I will call you right away if I find out that this is a problem. Understand, it's the best I can do. That's called based on empiric evidence. Look at the nature of the infection, where it's located, look at the gram stain, make the best choice you can because we want to treat it right away. Be aware and nobody, and particularly in medicine, nobody likes surprises. They don't. I can tell you people, oh, don't worry. After the anesthesia wears off, it's not going to hurt. Tell them it's going to hurt. Because if it hurts, then you look like a dummy. It's going to hurt like crazy. If it doesn't hurt, then you look like a hero. Psychology. I love that. So you start with broad spectrum. Once you know what it is, you cone it down to limit the spectrum. That's the appropriate way to do treatment. A lot of infections over a quarter of a century did I treat. Originally metabolic products of bacteria and fungi that were designed to inhibit the growth of competing microbes in their habitat. Remember the bacterial growth curve way back in the beginning? First exam. When you got that stationary phase, they form secondary metabolites. That's where we find antibiotics being produced. We can extract them, and then we can tinker with them. Greatest numbers are described from bacteria, Streptomyces, and something called Bacillus. You work with one in the lab. You worked with Bacillus subtilis in the lab, right? Did endospore stains. What does it make? Bacitracin, one of the things of triple antibiotic ointment. You can get pure bacitracin. It's too strong to be used internally. We use it topically. Triple antibiotic was a combination of neomycin, which is in the family of streptomycins, bacitracin, and something called polymyxin B. Okay, why is it of significance? It came from Pittsburgh. Burroughs welcome to Pittsburgh. I'm a New York guy. Sorry. Tyler's online today. We're originally a Giant. He's a Giant fan. I'm originally a Giant fan. Sorry, I'm a Steeler fan. Died nearly 50 years. Molds, penicillin, and cephalosporians. We're going to spend a lot of time with it. Before therapy can begin, okay, the identity. So we have to cultivate it. That's doing a culture. That's what you're doing in lab. That same thing, plating it out, whatever plating technique you're using. Are you using the T plating technique? Are you using quad plating techniques? You want to isolate it in pure culture, Kirby-Bauer test or something similar to that. Okay. And then we look at the person. Can they tolerate the treatment? Or what are they allergic to? Do we have a choice that's bactericidal? And years ago, one of the significant things, I told you how much Keflex I used. Sometimes we couldn't prescribe it. This is the days came around before when I started practice. We didn't have plans that paid for prescriptions. I can't use that, Dr. Stein. I can't afford it. I don't have the $40 or $50 that's going to cost. That's what it was like back 40 plus years ago. So that was another thing I had to take into it. Could they swallow it? Other medicines they were taking, et cetera, et cetera. Soon as possible. Right back to that bacterial growth curve. And that's from in vitro testing. Early identification and treatment occur before antimicrobial drugs are given. Much better to do it that way. If you do a culture and someone's already started, you have to let the lab know what they're already on. Direct examinations, that's something you can do in the office or you can do in the hospital or emergency room. We will look at samples of sputum. We'll look at saliva. We'll look at genital urinary secretions, et cetera, because you can do a direct examination and see that. And then immediate findings or informed guesses. That's what's called empiric evidence. Something that's there that says, I know this, so I can make this choice based on that information. And then, again, epidemiologically, something we talked about previously, to understand what's going around. It's like when COVID reared its ugly head, yeah, you kind of knew what was going on. We didn't have the luxury of the rapid COVID tests and all those types of things that are fairly reliable today. Or you can get them to use them at home. All you could do was say, okay, they have this, this, and this, based on who they were, anybody in their orbit, et cetera, et cetera. You might be able to make an informed judgment of that. Staph, Neisseria, Enterococcus fecalis, gram-negative intestinal bacilli. There's a lot of different areas that you'll test for. Fungal or protozoal infections, initially drug testing is essential. Exposing a pure culture of the microbe to several different drugs, Kirby-Bauer test, and observing the effects on those grubs. And so this is what you did. I don't know if you do, however they taught you to do it in the lab, because it's not me. We could do it creating a lawn of bacteria, 3 directions, 90-degree angle. We do it like that. Hey, pop the discs on it, however you do it, tap the discs in. There's a little gun that you put them on in the hospital. They do it fast. And of course, you measure the old zone of inhibition. That is, and it's something they should have pointed out in the lab, whether they made a big deal of it or not, is a qualitative, not a quantitative test. It's not determining what the dosage is from that. It's merely whether it would work or is likely to work or not. Qualitative is yes or no. Quantitative is a number, a dosing thing. There's other things we use for dosing. So I'm throwing a little lab in there. That's a typical thing that you would see. And again, you measure the zone, and typically it's greater than, less than, et cetera. And then the ISSNR, you've all seen that type of thing there. Measure it appropriately. There are other alternatives that you can use. I don't even know the name of that. Okay. Tube dilutions are there with tubes of broth. In the hospital, you get something, a doctor gets a report and it says MIC, minimum inhibitory concentration. Before they do the Kirby-Bauer test, you actually dilute it to an appropriate level and measure it with a spectrophotometer to make sure it's that. So there's a certain degree of standardization that goes on, not like we do in our lab. You don't have to. And then here you can see these dilutions, et cetera, et cetera. In vitro activity is not always correlated. That's the point I made about ciprofloxacin before. It's a lab test. That's all it is. It's all it will ever be. It's a living, constantly changing, easily altered environment. Inability of the drug to get where it's supposed to go. Biofilms can prevent it. We talked about that early on. Resistance in the infection that wasn't there in the sample. Okay, an infection caused by, we call it multiple or mixed infections. Very, very common problem today. Very common problem today. Possibility the patient did not take it correctly. That you can't mind. It's not like you're in the hospital and you're administering something by injection, either intravenously or intramuscularly. So you don't know whether they got it. Did they take the pills? A lot of people don't like to take pills. They don't feel it. I'm feeling better. I'm not going to take the damn pill. Here's the therapeutic index. So higher is better. Highest therapeutic index equates to safety margin. So all of this, pre-existing conditions, allergies, liver and kidney, because that's where we detoxify those things. You have to adjust the dosage. Particularly, liver is fairly obvious because, there's so much stuff that can go wrong when someone has liver disease. Kidney, because certain antibiotics don't clear the kidney. So sometimes, or people with ongoing kidney problems, you have to reduce it because it puts so much strain on them. All of these special programs, infants, elderly, pregnancy, drug interactions, combinations that could be problematic. That's why the underline with this, the idea is why it's a good thing for, not just for you or for your family, but for people that in your orbit, use one pharmacy or use one pharmacy chain. So whether it's Giant Eagle, whether it's Walmart, whether it's Walgreens, whoever it is, because that's computerized and it will come up. If the doctor prescribes something, they'll say, whoa. Because I've gotten plenty of calls from pharmacists going, did you know Mr. or Mrs. So-and-so was on this? It's important. So it's a lot of potpourri of introductory material. We're going to get to specifics next time. Goodbye. Nice chatting with you.